a patient of head and neck cancer comes to us, a cancer on the, the tongue,
Yeah.
so lateral border of the tongue comes to us.
Yeah.
Sometimes may directly walk into our OPD as a radiation oncology OPD because they see an oncology board, radiation oncologist. Sometimes they go into medical oncology or a surgical oncology. Now, whatever we do, it's always we see a patient, either I see or my colleague in radiation, in medical onc or in surgical onc see. These cases are upfront discussed in our multidisciplinary tumor board. The concept of oncology treatment is very personalized.
Yeah.
When I say it's personalized, the way I treat 80-year-old coming with a tongue lesion on the tongue is totally different from how I'm going to treat when he's 40-year-old, saving the normal structures and giving that care.
What are the advancements that you're really excited about when it comes to radiation oncology?
See, I told you one is about SBRT, which is come. SBRT is come a big way, probably in lung cancers, where you see elderly patients who are actually not fit for surgery.
One thing patients should never skip during treatment.
Oh well, this is very important. One thing you should never skip is stay calm, hydrate yourself, very important, and have a small meals. Like you don't have to eat 3 times per day. Every 2.5 hours, hydrate yourself, have a very well nutritionally balanced food.
One cancer where radiation has changed the game.
Well, radiation has changed the game, if you ask me, again in head and neck cancers.
Yeah, I also think this larynx cancer can also be a very good example.
Yes.
Earlier, it used to be removal of voice box.
And also, I'll tell you now, oropharyngeal cancers. See, oropharyngeal, you must have heard of HPV, human papillomavirus.
Yes.
Oropharyngeal cancers with a background of HPV. Most of the human papillomavirus are all oropharyngeal cancers in head and neck. So they are non-smokers. So they do very well with radiation.
Radiation therapy has come a long way, from vague fears to pinpoint precision in cancer care. In this episode, we unpack how it works, how plans are personalized, and what patients can expect. We will dive into tech like SBRT that's changing the game for hard to treat tumors. What are the side effects? What are myths? We bust common misconceptions and share practical tips for patients. Radiation therapy decoded, clear, current, and patient focused. Joining us today is Dr. Sanjay, a highly skilled and accomplished radiation oncologist with extensive experience in advanced cancer treatments, particularly in image guided radiotherapy. With a focus on treating cancers of head, neck, lungs, and abdominal region, his work reflects a strong commitment to precision, innovation, and compassionate patient care. Let's get started. Hello and welcome to Sahyadri Health Talks. I'm Dr. Tushita, and today we have with us Dr. Sanjay. Hello, sir. How are you?
Hi, Tushita. I'm good. How are you?
I'm good. Welcome back on Sahyadri Health Talks. We had an opportunity to invite you in the panel, and of course, the response was so overwhelming that we thought we should have a separate session on radiation oncology. So, thanks for accepting the invite and coming for the podcast. So, we will be talking about radiation oncology today and trying to understand how the role of radiation has improvised or made the cancer treatment overall better. So, but before we dive in there, you always wanted to be a oncologist or particularly a radiation oncologist?
No, frankly speaking, to be very honest, it happened by chance. I mean, I've never told anyone, but I always wanted to be an ophthalmologist.
Oh, acha. So that goes on records, I think, today. Yeah.
So by chance it happened, and then we are so much deep dived, into it, and we really couldn't come out and really started liking the branch and how you deal with people. I mean, it really connects you, it makes you feel how well you can connect to, patient who is suffering a lot. That makes really this branch, probably the oncology branch, could be anything, could be surgical, medical, or radiation. You deal in and out with these patients, and that connects me spiritually with those patients. So that's why I'm really blessed to be in this profession right now.
So why radiation oncology? Was it destiny again, or you chose this?
No, it was like I told you, I wanted to be an ophthalmologist. Usually,
Yes.
I mean, I think you're aware of the drill. We write NEET exams and then we get some ranks, and then on a merit basis. Probably I never had an ophthalmologist as an option for me.
Acha.
So then radiation was that time I knew a branch. No one wanted to probably come into that, and it happened by chance, and I took it, and it went ahead.
That it went, and it's going beautiful as we can see already. And kudos to the great work that the entire team and our doctors too.
That's right.
So let's dive into today's topic. So
Yes.
when it comes to radiation oncology, what is radiation oncology? I mean, I know by now almost everybody knows, thanks to the internet we have enough information available. So but still, to basically start with, what is a radiation oncologist's job, or what does a radiation oncologist do?
See, to answer this question, see, I'll tell you. Basically, oncology has three main branches. I think
The
everyone knows
surgical,
about
the
it.
medical,
Yes,
and the radiation.
radiation. So,
Yeah.
radiation oncology is one of the branches,
Huh.
and radiation oncology deals with treating the cancers with radiation. So,
Mm-hmm.
it's called radiation therapy.
Mm-hmm.
Okay, so now if you ask me how it works,
Mm-hmm.
basically everyone wants to know कि radiation क्या होता है, how does it help? And when someone who comes to me, because the idea as an MBBS graduate, when you are an undergrad, no, you're not exposed to the radiation as a separate subject. Though
Yeah.
you're dealt with medicine, you're posted in that, you've been in surgical or you've
Mm.
been in general surgery department, you know what happens.
Mm-hmm.
But radiation is something very unique. The closest you'd have gone through is probably into radiology department,
Yeah, radiology
which people still come and ask me, doctor, हमको radiology करने के लिए बोला है.
हाँ,
No, I
हाँ.
try to correct them.
Yes.
These are two different things.
हाँ, हाँ,
Now,
हाँ.
how radiation helps cancers? Well, you know, basically, it's what is cancer, and if you can understand what is cancer,
The
there's a defect in the
normal
growth of
of
cells.
cells.
So their DNA is defective.
Hmm.
Now, when we radiate, we try to hit those DNA cells.
Mhm.
We try to hit their double coil cells, and they fail to repair. So
Acha.
ultimately, they fail to repair and they die.
Acha.
So that's how radiation helps in killing the cancer cells.
Mhm.
Now, if you can ask me what happens, doctor, you're treating those cancerous cells, but of course, there are normal cells in your body.
Which
Now, what
gets
happens?
also
They also
impacted.
get damaged.
Yeah.
So that's how it's a trade between killing the normal cancerous cells and preserving the normal cells to an extent where the cure, the maximum tumor control probability is achieved by giving that quality of life and preserving those normal structures.
Yeah. So when it comes to the oncology or the cancer, overall cancer cases, it is usually the first approach is never to a radiation oncologist. I
Of
mean,
course.
we have still not reached that level where we know whom to reach out to.
That's
So
right.
typically we reach out to a medical oncologist, and eventually the panel, the board of oncologists discusses the case and then finds the right way. So what is the scope of this treatment planning of a
Okay.
patient, and how does it usually
Usually.
occurs?
See, again, it's like probably a patient of, I'm just telling you an example, a patient of head and neck cancer comes to us, a cancer on the, the tongue, so
Yeah.
lateral border of the tongue comes to us.
Yeah.
Sometimes may directly walk into our OPD as a radiation oncology OPD because they see an oncology board, radiation oncologist. Sometimes they go into medical oncology or a surgical oncology. Now, whatever we do, it's always we see a patient, either I see or my colleague in radiation, in medical onc or in surgical onc see. These cases are upfront discussed in our multidisciplinary tumor board. I understand now the concept of oncology treatment is very personalized.
Yeah.
When I say it's personalized, the way I treat 80-year-old coming with a tongue lesion on the tongue is totally different from how I'm going to treat when he's 40-year-old. So there's a lot of difference.
So it's like complete customization and personalization of the treatment plan.
So when they come, probably I'm just dealing with one example, a tongue cancer comes to our OPD, usually referred because operated, and then comes with a histopathology report. So when they come, we probably look at the patient's age, we look at the other pathological factors like what was the tumor size, what was the nodal status, and then we decide to radiate the patient. And there are certain guidelines or protocols given, we always follow those guidelines. Say head and neck cancers, you treat almost for 30 days. Now 60 gray in 30. Now, when I say gray, looks like a layman term to a lot of people. Gray is a unit of radiation.
Achha.
Very simple. The height you always measure in centimeters. The amount of water you drink is always measured in liters. And the radiation dose is always measured in gray, GY.
Achha.
Okay, so that's a unit of radiation. So we plan the radiation, but before everything, first we see the patient, we examine, we stage the tumor, and then we start marking the area where needs to be treated. So the first step after the clinical evaluation of the patient is something called simulation of the patient.
Achha.
So simulation, as the word says, it's like simulating the treatment area or the simulating the treatment setup.
Okay.
So simulation is done basically in a CT simulation rooms. So most of them have a dedicated CT simulation rooms. Otherwise, we do it ourselves in the diagnostic CTs. So what we do, 30 days when the patient is, I'm sticking to the example of a tongue cancer. Patient is getting treated for the tongue cancer. He has to be coming to meet us for 30 days. So the 30 days, his position, the way he's comfortable, because treatment time is going to be 10 to 15 minutes daily.
Acha.
So what we prepare in the simulation is we immobilize him, so that you cannot move your head here and there, so
Yeah.
that my radiation is going to miss.
Uh-huh.
So we immobilize him in a particular position,
Hmm.
put a small thermoplast mask.
Mm-hmm.
They are customized mask, mind
Mm-hmm.
you. And suppose I'm using a mask on you, I cannot use the same mask
On
on another
somebody
person,
else. Yeah.
because the dimensions of a face differ
Correct.
from person to person.
Hmm.
So it's a reusable mask, but
Hmm.
again, we don't try to use it. We melt it, it becomes a flat thing, and then put it on the face. So
Acha.
that mask gives them an immobilization.
Hmm.
So patient doesn't move.
Yeah.
And then we mark the area where to be treated. Probably it is like there's a scar on the neck after surgery, there's a scar inside the tongue area. So we wire that scar so that we are clearly able to treat what was actually operated. So once that is done, it's a software again, we do a scan, the images which we get are all sent into our system. So on the system, basically we sit and we start drawing the tumor, which areas were involved, probably the neck or the entire tongue, which area, and they do that, and we give a particular dose.
Acha.
Radiation oncologist decides what dose to be given based on the general condition of the patient, based on the age, based on
And
any
again, the
comorbidities.
customization and the
Customization stands there,
personalization comes in
comes in.
picture.
After that, we start planning on the patient. So
Acha.
the plan is basically done by, I'll tell you, very professional radiation physicist. Now,
Acha.
even a radiation oncologist cannot sit and plan. It is actually the radiation qualified radiation physicist who sit and put the beams. Radiation is nothing but an X-ray. They decide from which angle to hit, how much dose you can give. Because suppose I'm treating a tongue, there's always a parotid which is closed. There is always a
Because we
swallowing
have to
structures,
save the supporting nearby
nearby
structures, which are
structures.
quite important.
So they then do that, the planning is done, and once the planning is done, we call the patient the next day probably, and then take them into the radiation room, that is a linear accelerator room. And then the exact setup is replicated like you did the simulation. Probably you put the mask again, the same couch movements where the patient is lying, point him again, mark that area, check, and then do a CT and check whether we are radiating correct or not. That's called a quality check of the patient. So QA is being done. And once the QA is done, the radiation is delivered. So for treating a patient, it's not like you walk into the OPD and then you start your radiation. So this entire process may take 2-3 days, and then I start my treatment.
So this is the entire treatment plan and how you plan the before giving the treatment. So when we talk about radiation oncology, like any other fields of medicine, which has seen tremendous growth and advancements, right? Radiation also has seen and is still we are seeing so many new modalities coming up.
Yes.
What is this SBRT, and what are the other advancements in radiation oncology that you see, which has helped you give a better patient care?
See, again, if you ask me about SBRT, it's called stereotactic body radiotherapy.
Acha.
Must have come probably 10 years back or 15 years back, when a lot of things came into SBRT. SBRT is again a form of radiation. It's a form of radiotherapy, a technique of radiotherapy, where a very high dose is given to a particular cancer site.
Okay.
Now, traditionally, if you ask me, we treat head and neck cancers, breast cancer, we fraction it. We give 15 days, 20 days, 25 days. Now, what SBRT has done is probably delivered the same radiation in 1 to 5 days. And there are very specific tumors where we deliver. SBRT, if you ask me, practically where we use these days very commonly in a metastatic setting.
Acha.
See a breast or probably see a lung. Someone comes with a bone metastasis, a lesion in the vertebrae, or a lesion in the small lesion in the lung from the breast, a small lesion in the liver.
Acha.
So where SBRT comes into play, where we give very high dose to that region.
So very high dose and shorter.
Very shorter course treatment of
course
time
of
and very
treatment.
high dose,
Okay.
giving the same results, but again keeping the principles of saving the normal structures. That is very important. Now probably it has replaced. Now if you ask me how good or how it has come up,
Yeah.
it is probably replacing surgery in many scenarios.
Oh, is it?
Such small
Okay.
tumors, surgeons are always keen to go in and operate. Now the difference is it gives the same results, but again it's a non-invasive,
Yeah.
shorter treatment time.
Yeah, and patient also gets very comfortable. No?
And there's no admission, there's no scar, there is no cut.
Yeah.
You operate a small lung tumor which is there at a small liver, there's obviously going to be a scar on your body, which patient might not like it. So SBRT is a stereotactic body radiotherapy, probably 1 to 5 sessions, no scar, no admission, daycare procedures, non-invasive, very important.
Very
and again
important.
keeping up to the principle of saving the normal structures and giving that cure.
What are the advancements that you're really excited about when it comes to radiation
See,
oncology?
I told you one is about SBRT, which is
Hanji.
come. SBRT has come a big way, probably in lung cancers,
Hmm.
where you see elderly patients who are actually not fit for surgery.
Mm-hmm.
Lot of lung cancers now happen because of smoking.
Mm-hmm.
Most of these patients have COPDs. Most of these patients are not fit for anesthesia.
Mm-hmm.
Okay, and again the liver cancers, alcoholic patients, livers,
Mm-hmm.
they are liver cirrhotic. Most of the patients are not amenable for surgery. So
Mm-hmm.
where SBRT comes in and gives a very good
It
dose, it
acts as a
is
savior.
savior. It is in fact replace surgery in many scenarios.
Mm-hmm.
But again, I'll tell you, surgery is the step, is the first step.
Mm-hmm.
We prefer radiation in patients like this who are not fit for surgery. And if you look at advancements, how they have come, I'll tell you, maybe 20 years back or 20-25 years back, we used to treat radiation with a simple X-ray based machines. The radiation used to hit, and radiation used to be just, the scans used to be done with X-rays. Suppose I'm treating a lung cancer or a head and neck cancer, the entire area, the scans which you take used to be an X-ray image. We've evolved. Now we have come to something called CT images,
Mm-hmm.
and now we've also come to MRI images. So that's the evolution.
Mm-hmm.
And the technique wise, the most common technique for most of the cancers now is image guided radiotherapy.
Mm-hmm.
So image guides us what to treat. We are
Mm-hmm.
not shooting blindly.
Mm-hmm.
We are knowing what we are shooting,
And
because
where
the
we are doing
where
it,
we are
and very
doing very
precise,
precise.
basically.
So that is come. And again, I'll tell you, recently now the world is moved into AI. AI has come big way, machine learning and AI.
Yes.
So probably in our department now we have a model where we feed in the tumor details, we feed in the the tumor characteristics. Probably it's going to tell us how the patient is going to fare after radiation.
Acha.
So that's an AI based. So females with left sided breast cancers, the most important thing is saving the heart. Everyone treats breast cancers, it is very easy, but eventually this heart complication pop up after 10 to 15 years. That's a late complication, and they end up with MI, they end with cardiac myopathy and all. So what we are doing for such patients is we are treating something, we are checking upfront whether these patients are suitable or not. So then
Acha.
AI based model, machine based model. So you scan, and we realize what will be the dose to the heart when we are scanning. Is this patient really suitable for a breath
So
hold
basically,
technique?
even before giving the treatment, you
You
know
know
what
what to do.
might be the possible
Complication,
complications,
and
and
also
you handle it more.
what technique to use.
Acha.
Because suppose you scan the patient, you're using the technique, but ultimately the result is what you're anticipating, you're not getting that
It's
result.
not getting,
So it's entirely a waste of procedure. So
Yeah.
here it saves our time, saves our energy, and also very good for the patient, because we know upfront where this patient fits in, whether he goes to this line or the other. So that's the advantage of AI based learning. And again, if you ask me, I think in the last podcast also I said something really excites me is flash radiotherapy. Something that's I just love that, because now we're giving, conventionally when you're treating patients, we're giving 2 gray per fraction, 2.5 gray. Now with flash radiotherapy, which might be future in another 10 years, you can give upfront almost 50 to 60 gray.
Okay.
So that's in a minute of time.
Acha.
So that's how the radiation has evolved. The
Evolved.
flash radiotherapy,
And is showing
promising
results in
and you
future.
also must have heard about proton therapy.
Yes.
Most of you must be asking you, and you Google and you get proton.
Yes.
Probably in India it's there in Apollo, Chennai and Tata Memorial, but the cost is always an issue. So very sooner proton is going to become very common,
And very affordable
very
for people.
affordable. Apart from proton, there'll be always something called carbon ions. They're
Acha.
heavy particles.
Acha.
So the way they treat, see, the radiation principle is to treat the tumors, give least side effects to normal structures. So when using these protons or heavy ions or carbon ions, the complication rates are very, very, very less.
Yeah. So when it comes to oncology, I mean, a patient who is diagnosed with cancer, that itself is a very spine chilling thing for the patient, and requires a lot of emotional and mental strength. Why I'm referring to this here is because there's a lot of emotional counseling which you do day in, day out for such patients. So how do you manage this emotional counseling, or patient counseling, when it comes to explaining a patient about such complex radiation procedures, and how does it work?
So it's always taxing when a patient comes to us. You know what they've gone through.
Yeah.
Probably there are times when they see us first, the radiation oncologist. Probably there are times when they see you last,
Yes.
when they've finished the surgery or probably
Yes.
chemotherapy.
Yes.
So the patients who have finished radiation and chemotherapy, they're like, "Abhi bas kar do yaar, we are not having any strength."
Correct.
So the moment you see the patient, you don't directly jump in and say कि your stage is this, आपका ये है, आपको इतना दिन का radiation देना पड़ेगा. You, how well you connect is important. With the patients, it's always family members who come, probably a patient's wife or son or someone close, a child will always be there. So always understand what is their need. I always make sure I talk to the patient. Sometimes आके बोलते हैं कि सर हमको डॉक्टर को डायग्नोस आई मीन पेशेंट को डायग्नोसिस नहीं पता है, प्लीज मत बोलिए. बिफोर
Yeah.
ब्रेकिंग दैट न्यूज, आई मीन आई आस्क देम, अभी तो सर्जरी भी हो चुकी है, कीमो भी हो चुका है, स्टिल द पेशेंट इज नॉट अवेयर. I mean, that becomes a stigma you need to handle.
Yeah.
So we need to be very delicate, we need to be very sensitive at the time, talk to them what is going through. You try to tell them what is radiation in a very simpler form. The best thing what I've done is ask patients about, I tell radiation is nothing but an x-ray. You take a chest x-ray, it's the same thing, please come and take, and slowly introduce them to complications rather than bombarding it with the information which you cannot digest, the stress, the anxiety which they'll have. So you cope up first. About It's all about speaking
Conditioning
to
the right.
conditioning, speaking. And the second thing is, now I just gave an example of head and neck cancers like
Yeah.
tongue.
Yeah.
Patient is going to be with us for 30 days.
Mm-hmm.
It's like you go to a mall, you go to a shop, you buy something and come back. You go to a cinema mall, you enjoy the movie and come back. But imagine you're doing the same work for 30 days.
Yeah.
So what is very important, which my staff always gives, is we have very trained radiation technicians, radiotherapists, the people who are inside, who set the patient up and all. So patient needs to get that comfortable approach, or should feel comfy with those technicians, because they don't see my face daily.
Yeah.
I am there for any problem round the
Yes.
corner, I can come and talk to them.
Yeah.
But these are the people who hold their hand, take them inside, make them lie down, put the mask, talk to them. So unless and until they become very familiar with the patients, the treatment is not going to be smooth. So it's very important to have that connect,
Connect
which
with
I
the
always tell
patient.
my staff, keep, please deal like their own people.
Mm-hmm.
Though they are patients, they've gone through a lot, so get over it.
Mm-hmm.
And third thing which I've noticed in Indian patients, particularly like probably who are from rural areas, they come, I mean, we tell we're going to start the treatment, and they tell doctor हमको, we just want to go to our religious place. A deity is there, घर, I mean, भगवान है हमारे पास, वो घर के पास है, हम लोग बहुत मानते हैं, हम जाके आते हैं. Don't stop them. Don't tell them कि please don't go there, this doesn't work. I know it's not like God who's going to save you out of this. Yes, that beliefs,
And
give
that
them that
emotional
support,
strength
very
also,
important.
right?
So you-
Psychologically, they
very
become-
important. If someone tells me I want to go there for 2 days in the weekend and then continue my treatment, I'm always open to it. I'll tell, go, come back, please take the blessings whomever you want. So don't discourage them from any of this cultural and religious beliefs. Probably that works very much in Indian population when you come from this, and
Yeah.
probably who's already gone through so much
already.
it doesn't make much difference. Always help.
Mm-hmm. That's so beautiful to hear, that kind of comforting that goes in. It's just not the treatment, but a lot of other things which comes in play.
Please. Yes,
Especially,
because more than treating, I think this plays a very vital role.
Yes.
Everyone treats.
Yes.
Now, why you become a very unique doctor is
Uh-huh.
because you need to have that connect.
Okay.
Probably someone meets me after 1 year. I'll tell you an example. A patient which we treated, a cervical cancer,
Uh-huh.
came for us for 25, 30 days, finished the radiation, went back, and suddenly a message comes to you after 1 year saying, Doctor, we almost 1 year now, we've done the scans, you're all cured. So they are so well connected because they want to tell each and everything to you. And they suddenly pop into the OPD, hi doctor, do you remember me? You treated me last year.
Yeah.
I'm like a bit changed. So that's so, that's, you
Heartwarming.
feel heartwarming, and you feel like you've done something really good. Though the efforts which I put is nothing. But these minor things really matter when you're on a longer run.
On a longer run, that's true. And now, as we spoke, right, you spoke about patients who are trying to fight this out by with their emotional belief also, that hame idhar jana hai, and requests like that. What are the common things, or what are the few things that you wish every patient would know before they come for a radiation oncology?
See, first of all, whenever they come for radiation oncology, it is very important to make them comfortable. You tell them this is a simple process. Radiation therapy is something which you haven't heard. You always see patients with a scar. You understand surgery is done. You always see some chemotherapy given in saline. So you know what is happening. But radiation therapy, you need to be very comforting. The way you're walked in, you're going to walk out the same way. Only thing is, we make you comfortable in a simulation room. We put a small mask or immobilization devices if required. And then during the treatment, you finish treatment and again go back home. So you're coming in one piece and you're going back in one piece. There'll be no any untoward changes in your body. Yes, I always tell them the complications they're going to face. Could be a minor, but none of the complications of radiations are like long term and life threatening.
So, what are these most common complications that we see?
Well, radiation complications are site specific.
Acha.
Okay, so I'll tell you, I'll take three scenarios. Probably most common
Most
scenarios in
common.
India, which you see, head and neck cancer is most common. Breast cancers again, most common in urban women, and in fact, number one in India now. And gynecological cancers like cervical cancer.
Cervical
So,
cancers.
so let us take head and neck cancer first.
Hanji.
I'll just tell you 4 or 5 points what you usually see. Radiation again, I'll tell you, is an X-ray. Only deep-seated tumors के लिए use high energy X-rays to treat so that it penetrates into the tumoral tissue. So when you're treating head and neck cancers, the first thing what you get, it's a myth again. Patients come and say burn hota hai kya? No, it's called dermatitis. I think you understand what is dermatitis.
Yeah.
It's basically skin reactions.
Yes.
So that skin reactions occurs because we are all brown skin people. We all have melanin in us, and the radiation hits this melanin compounds to and gives the change in the color.
Yeah,
So that's what you see is little blackish, little reddish. So that's the first thing bound to happen with any side you treat from head to toe. And suppose in head neck cancers, I'm treating tongue cancer, as I said, I'm going to also treat the neck areas where the lymph nodes are there. So there'll be going to be something called mucositis, मुंह में छाले आना, white dots inside the mucus bound to happen. So patient should be knowing this because this is going to come after 10-15 days. And if you don't explain this, they may get panicky. They may tell क्या हो रहा है, समझ में नहीं आ रहा, हमको radiation बंद करना है. Third thing is most of the normal structures are also in this. Parotid is one. Parotid, you know, the function is causes saliva and produces saliva.
Parotid gland functions.
You keep radiating, becomes dry, so your saliva dries up. Patient
So
feels कि
xerostomia.
xerostomia, taste नहीं आ रहा है हमको, बहुत ये होता है, दिक्कत होता है, खाने में चबाने में तकलीफ होता है, निगलने में तकलीफ होता है, dysphagia, because most of your swallowing structures get some amount of
That's
radiation.
right.
Whatever I try to do, any technique, some amount of radiation goes.
Yeah.
But this is not a permanent damage. That's what I tell my patients.
That once you stop, once the treatment
It's
is
reversible.
over, it's reversible.
Reversible.
Yeah.
Maybe yes, we give medications, we counsel them, supportive medications to go through at least for, might last for 2 to 3 months. But yes, something which lasts longer is a dryness. So we give them salivary spray, which they keep using so that their saliva is there so that they start tasting food. बहुत सारे पेशेंट्स ये भी बोलते हैं हेड एंड कैंसर्स को तीखा नहीं खा सकते, कुछ भी खाए सर हमको बहुत जलता है, बहुत बर्निंग होता है. Yes, I agree, I empathize them and I tell them this is going to happen maybe 6 months. So the only advice I give to such patients is slowly introduce yourself to spicy foods. If suppose the best way I tell you is a family came to me and saying कि सर ये पहले 2 मिर्ची खाते थे, अभी एक भी नहीं खा पा रहे, तो I tell see मिर्ची is bad for your health. It's not like every day you have, but at least start with 1/4 of मिर्ची. 3-4 months के बाद आधा डालो, 1 साल के बाद एक डालो, so slowly it gets used
slowly,
to
increase your
tolerance to that.
towards
That's how
that.
you counsel the patients and tell them.
Yeah.
So coming to the complications of again the most common cancer we treat is breast cancer. The radiotherapy with breast cancer, again the first thing, skin reactions, dermatitis, most common.
Yeah.
And second is the radiation when you're hitting the breast cancer, breast tumor, it hits the lungs also.
Yeah.
So there's always a risk of pneumonitis.
Again, another vital organ.
Vital organ, so 1 to 3%. But the most critical organ, which we need to be worried, or which as a radiation oncologist I'm always worried, is when I'm treating left-sided breast cancers, and that is the radiation to the heart. So overall, it's a late complication. Maybe after 10 years, maybe after 15 years, you experience cardiac complications, which are a late complication of radiotherapy. So, but again, as I said, the various ways of reducing it, by using advanced techniques, by using deep inspiratory breath hold, that is called vital hold, which is with Sahyadri Hospital, and that is Asia's first. So that really, gives so much advantage. We can get down to dose of the heart almost 75% less than what actually we deliver without using this technique.
Without using that. Okay.
And again, the most common cancers we treat is again gynecological cancers, women may, cervical cancers, the area of pelvis being radiated, very sensitive area. Mucosa is also there, so they might experience some kind of mucositis, some pain while radiating, because while passing urine they might feel little burning sensation.
Achha.
Because the area is very sensitive, the radiation hits that part. And again, when they're passing stools there might be some burning sensation. So the best thing is always use an advanced technique like image guided radiotherapy. See what you're treating so you don't blindly shoot. And second is the diet. The diet has to be strict. Avoid spicy food, avoid masala food, which really irritates your bowel. So keep it bland, keep it very simple. So what you eat really matters in these days.
So all in all, we can say that most of these side effects which are there as a part of radiation therapy almost all of them are reversible.
Reversible, that's right.
And it might take a little time,
Yes,
but then that is something which patients have to understand and be mentally prepared about,
that's right.
that none of these are permanent and these can be all reversed upon. So yeah, that's about that. And now moving on to the next segment, which is I have few questions, few lines which are can be a myth or a fact.
So this is rapid fire.
Yeah, that is the rapid fire. So I have some questions also here, and some common myth and facts. I'll read out those, and you'll have to help us nail it
Debunk the
down.
myth, that's
So
right.
let's get started with that. So the first one is radiation therapy is always painful.
No, not at all. I
Mhm.
told radiation is like an X-ray.
Yeah.
Never pains. The complications also I just mentioned. It's like site specific.
Mhm.
Radiation is not a painful procedure at all.
Okay. Patient receiving radiation becomes radioactive.
That's always a myth. I think the last podcast also we had
Yes, we
this.
spoke
See,
about
it's
this.
there's no residual radiation left in your body when you're
Hmm.
radiated.
Hmm.
Suppose this is radiation room. You're taking radiation. You walk out of this room.
Hmm.
Radiation is off.
Hmm.
You don't carry that radiation with you wherever you walk.
Hmm.
So that's a myth again.
So this also rules out the myth that if you are taking radiation therapy, isolate yourself from kids, from pregnant women,
Yeah,
eat in separate plates. So
these are
all
all myth.
that, you are
Yes.
not radioactive. Radiation therapy is only used for advanced or incurable cancers.
Well, not really. It's like very early cancers. Now I'll tell you an example of larynx cancer. It's an head and neck cancer, voice box, what we call larynx cancer.
Yeah.
Early cancers, we are looking at organ sparing.
So removal of larynx
Organ
was the
is
only
only option
option.
then. Now we are treating only with some amount of radiation there and you're cured, giving you almost 95 to 100% cure.
Yeah, correct. So radiation therapy significantly increases the risk of developing new cancer.
Partly, yes, I would say may not be a myth, but yes, there are instances, the reports where you treated breast cancers and you treated in a younger woman or lymphomas being treated. Maybe after 15 to 20 years, the risk of developing secondary cancers is almost 1 to 2%.
Acha.
That is beyond 15 to 20 years.
Acha.
And usually we counsel the patient when a younger patient, suppose a younger woman, 15 to 20-year old or a male comes to us with a lymphoma of the mediastinal area. We treat and we see residual. I mean, you follow up after 15 to 20 years, there might be a chance. It's a all or none phenomenon. It's not like everyone gets it, but some.
But some get it. Most common side effect that you see.
Well, again, it's site specific. If you pinpoint and ask me as a rapid fire, I'll tell you the skin reactions are definitely going to be there. That's the most common.
One thing patients should never skip during treatment.
Oh, well, this is very important. One thing you should never skip is stay calm, hydrate yourself, very important, and have a short small meals. Like, you don't have to eat 3 times per day. Every 2.5 hours, hydrate yourself, have a very well nutritionally balanced food. Very important.
I'll add one more to that. Don't miss your follow-ups.
Very important.
One cancer where radiation has changed the game.
Well, radiation has changed the game, if you ask me, again in head and neck cancers.
Yeah, I also think this larynx cancer can also be a
Can
very
also
good
be.
example.
Yes.
Earlier, it used to be removal of voice box.
And also, I'll tell you now oropharyngeal cancers. See, oropharyngeal, you must have heard of HPV,
Yes.
human papillomavirus.
Yes.
Oropharyngeal cancers with a background of HPV. Most of the human papillomavirus are all oropharyngeal cancers in head and neck. So they are non-smokers. So they do very well with radiation. The
Acha.
cure rates for someone who is human papillomavirus positive, HPV virus positive, is tremendous. The same stage 4 cancer might get a cure of 70 to 80% for stage 3, stage 4. The same with HPV driven, HPV positive will almost 90 to 95%. So that is because they respond well to radiation.
Acha. Your go-to advice before starting treatment.
Well, my go-to advice to the patients is we are always there with you. You are here. We always have an eye on you. Don't feel that
Left
you're
out
left
or-
out. Very important that is. And follow the instructions given by us during treatment, after treatment, and when you come for follow-ups.
Sure. Go-to food during treatment.
Very difficult to answer because.
But I'm very sure this must be कि क्या खा सकते हैं बता दीजिए डॉक्टर.
Yes, we can take it that way. What to eat? Probably any food which is very light on your stomach, very bland, not spicy, not very masala food like Indian food has a lot of masala.
Okay.
Best go-to food is your favorite food. Probably want to have a khichdi at home. That's the best.
Okay.
That's like the soul craving food. Most of them have it.
Yeah.
So have that and have some good nutritious food. Always consult a dietitian. We always have in our department a dietitian who takes us through and caters what you need based
Hmm.
on your site
Hmm.
which you're treating.
Okay. Is there any particular things to keep in mind when it comes to typically non-veg food or veg food?
No,
Uh,
see, a lot of people are vegetarians.
yeah.
Lot when we tell about non-veg, they say, "Doctor, we are pure veg."
Huh.
Yes, at least for such patients, I ask them to eat egg
Hmm.
because egg is again like both.
Hmm.
So sometimes, so I tell them if you are eat egg, then consume egg whites, which gives
Hmm.
you a lot of proteins.
Yes.
Basically, your diet or your treatment ke time pe you should have a lot of proteins.
Yeah, that's why I asked because non-veg is a known source of direct protein. So, but then a lot of myth is around कि किसी की भी तबीयत खराब होती है तो they typically the first thing they do is skip non-veg. So that's why.
Not really. In fact, I tell my patients कि आप chicken soup पियो.
हाँ जी.
Chicken soup has a lot of proteins.
Mhm.
Remove those, the broth. I mean, just have a clear soup.
Clear soup.
Sometimes even prawns. See, they
Mhm.
are a very good source of proteins. Fish, very
Mhm.
good source. But don't make it like very spicy.
Mhm.
Fry it a bit.
So control the spice
Control the
levels,
spice and
oil
have it.
levels, and then you can have anything
Of
that you
course.
wish to. Okay. Lifestyle changes that you suggest while taking radiation therapy.
Lifestyle changes I would suggest is don't sit in a room and brood over what has happened to you. Be active, continue your work. There are a lot of patients who come to us who go to office, take treatment, and again come back who are there working offline. I mean, working from home and finishing. So my only advice to them is we are with you. Continue working. Don't lifestyle modify kuch nahi karna hai. Radiation is not like it's going to disable you. Radiation is a day in day out procedure which you take for 15-20 days. Continue your routine morning walks like your breast cancer. Continue your exercises, very important. And avoid during treatment something like smoking or alcohol.
That's I mean, we have covered almost everything on that
Yeah,
topic, and
almost.
it was so beautiful to discuss in depth about this radiation oncology, which was a need of the hour, is what we felt. Anything else that you want to add up before we wind up this podcast?
No, I think we covered most of the points. I
Yeah.
think the previous podcast was fantastic. Even this, I think, should really be like the radiation podcast where patients, most of the queries which they have, they Google, can get answers on this.
Sure. On that note, thank you so much once again for
Thank you.
giving us this time
Thank you,
today.
Dr. Tushita.
And
Thanks
it
a lot.
was lovely having you as
Yes.
always. Looking forward to have you again on this podcast. Until
Thank
then,
you.
we wish you all the
You've
best.
been a wonderful host. Thanks a lot.
Thank you. And that's Dr. Tushita signing off, Sahyadri Health Talks.